kind of a special session that just came through my mind that actually got a lot of people that requested for so-called bedside teaching that I cannot really commit at all. But what I can do is perhaps uh, to actually practice on how to present, because I think the most important thing is sometimes the short cases is the one that usually make us fail the exam instead of the com skill or the consultation scenario. So why is it happen in exam is because a few reasons. First is either we the limitation to detect a certain what we call as a hard sign. That means the signs that the examiner has calibrated, and or in certain cases actually the candidate appreciate all the signs. It's just that don't know how to put things together and present it out. Because if you don't mention about that particular sign during our presentation, then we won't be get the marks under the marking skill. Okay, so I will just today our focus is just going to be on abdomen and respi. Initially, I was very ambitious. I want to try to do all four station, but it's very heavy. I've realized that. So I will split into the two session. So tonight is just session one, and then maybe somewhere along the line, probably by this weekend or next weekend, we see how it goes because we will have a second session later. And in terms of the marking scale, I want everyone to be aware that um, this yeah, so the component for the short cases is all the same, meaning physical examination, the examiner see how we examine the patient, and then what sign that we elicited and also presented. The most important thing is actually we have to say out the sign in order to get the marks, and then we offer our differential diagnosis as well as our discussion mainly on the investigation and management. And throughout the session, in terms of the short cases, it's also important to maintain the patient welfare, making sure that we don't cause unnecessary pain to the patient. And then always ask the patient, do you feel any pain before you proceed? Okay. So this is like a very informal way to practice the exam, I think, because yeah, so I saw that someone is actually raising the hand. Danita Mary, is it? Do you have any question want to ask me? Oh, okay. The hand is not raised anymore. Okay. All right. So I realized that maybe there is a creative way of preparing the exam instead of always following the exam format. That's why I decided to do this kind of like short, rapid fire, but hopefully productive kind of session for more people to actually practice. So how do we conduct this tonight's session is we will every candidate will be provided a total of 5 minutes. So I will give 1 minute to just look through the scenario. Basically, this scenario is like how you go through your mind when you examine the patient. What are the signs that from peripheral for a particular target organ that was asked in that particular station, and then after you examine the particular region of the body, and then what is the other thing that you want to do. So this is basically just all the sign that's compiled in just one slide, and I want the candidate to read through, and then the remaining 4 minutes is just same as the real exam. I'm just going to time the 4 minutes. So meaning to say, I want to hear the presentation of the sign that was displayed in the first 1 minute, and then want to present it in a way that you can try the best to present. You can do it any style. There's no particular format to it, and then try to finish by 1 or 2 minutes time, followed by 1 minute discussion with me in terms of investigation, and the last 1 minute for management. Okay, so this is ideally how it should go for tonight. So I understand that the first candidate tonight is actually Cardigan. Is it? Cardigan, are you there?
Yeah,
Yeah, Cardigan, right? Cardigan.
yeah, Katiban. Yeah.
Cardigan. Okay. All right. So what I will do is actually I will give you 1 minute. Okay. So after 1 minute, so just relax. So you just read through the slide for 1 minute, and then you think how you want to present about this patient, and then you will present it when the time's up, just like how you present the exam. Is it okay?
Yeah, okay.
Okay. All right. So we will start the 1 minute. Okay, time's up. Okay, Dr. Kadiman, can you tell me what have you found in this patient?
Okay. I've examined is currently comfortable at rest. On peripheral examination, there is generalized muscle wasting with digital clubbing as well as palmar erythema. Uh, there, I've noted bruises over the bilateral arms with tattoo marks, with jaundice as well as pallor on examination of the eyes. There is presence of spider nevi and loss of axillary hair with gynecomastia. Putting all of this together, as well as on examination of the abdomen, there is umbilical hernia with dilated veins, as well as hepatosplenomegaly, and the drop space is dull with positive ascites. Putting putting all of this together, this patient has signs of liver uh, stigmata of liver cirrhosis as well as hepatosplenomegaly with ascites, likely uh, chronic liver disease with portal hypertension in a decompensated state.
Mm-hmm. Okay. And how about etiology?
So, based on my examination, presence of tattoo marks uh, puts the condition of viral hepatitis a possibility. Other possibilities could be fatty liver disease, uh, as well as liver cancer,
Mm-hmm.
and
Any
also can
other
be
difference?
infiltrative conditions like hemochromatosis or autoimmune hepatitis.
Okay.
Yeah.
Okay. All right. So how do you investigate this patient?
So for investigation, firstly, I would like to start with a full blood count to look for patients whether patient has any anemia or any thrombocytopenia, uh, and then liver function tests, patient's albumin level, patient's any raised transaminitis, otherwise a coag profile to look for any derangement. Uh, Other investigation would be also renal profile to look for any hepatorenal syndrome involvement. Etiology wise, I will sign for hepatitis B, hepatitis C, viral HIV, and then also fasting lipid profile, fasting sugar profile for this patient. Uh, Autoimmune screening, I would also like to send for any liver specific antibodies. Uh, Yeah, so this would be my blood investigation. Other investigations would be imaging. So I would like to do a ultrasound of the hepatobiliary system. Uh, yeah, and then
You have mentioned that the patient have ascites, right? What is your
yeah,
investigation that you want to
yeah.
perform?
So for the ascites, I would like to do a diagnostic as well as a therapeutic tapping for this patient. So I would like to look at the serum ascites albumin gradient to see if this is a portal hypertensive cause or non-portal hypertensive cause of ascites. Otherwise, I would
Okay.
also
All
like
right.
to look for any cell count for any peritonitis.
Mm-hmm. Okay. How
Cell
do you
count and
manage
cell
this
culture
patient?
would extend. Sorry. Yeah.
Yeah.
So
How do you manage this patient?
for management of this patient,
Okay. Time's up.
non-pharmacologic.
Yeah, but you can continue.
Yeah. So for management, I'll divide non-pharmacological will firstly to educate the patient about his condition, and then it will be a multidisciplinary team approach. Uh, patient will we will have to treat the etiology as well as symptomatically manage him. So for the decompensation part, I will also treat his portal hypertension and the complications that can arise, like upper GI bleed. So he may need scope, and then hepatocellular carcinoma screening for this patient as well.
Okay. And okay. How about the medical management
Yeah. So
in case of ascites?
so uh, for the ascites, yeah. So will be mainly diuretics, and then as well as spironolactone, and then we can start him on beta blocker carvedilol as well as spironolactone for this patient.
Okay, all right. And then how about portal hypertension? You mentioned about screening, right? So
Yeah.
what other things that you want to order?
Okay, so for other hypertension, mainly we worry of upper GI bleed, so we can do endoscopic evaluation and then bending if there is presence of esophageal varices depending on the grade. And then,
Okay.
yeah,
Mm-hmm. Okay, all right. I think I will just stop here. How do you think about your performance?
I'm a bit nervous.
Nervous, yeah. So I think it's a
Yeah,
bit
it's a bit
not fair for
disorganized.
you because this is too artificial lah. Because I shouldn't put the finding on top of the slide for you, right?
Yeah, so
So
it like clouds my way of presenting actually.
yeah,
I
yeah.
want to.
So I think I will just give you. I think I will just give you one more try, just
Okay.
to calm yourself down, and then I just give you one more try, just to present your finding, and then
Okay, sure.
give the diagnosis as well as the differential diagnosis. Okay, all right. So
Alright, yeah.
Dr. Kadiman, would you mind to tell me what you have found in this patient?
Okay, so I've examined this middle-aged gentleman who is currently comfortable at rest. So on peripheral examination, this patient has signs of stigmata of chronic liver disease as evidenced by clubbing, palmar erythema, bruising, as well as uh, jaundice and pallor. Coming to his, otherwise, I also know that this patient has evidence of tattoo marks with presence of tattoo marks on the peripheries. So coming to abdomen, there is a gross umbilical hernia. Uh, on palpation, I'm able to appreciate hepatosplenomegaly as well as positive shifting dullness in this patient. This patient also bilaterally. So, putting all my findings together, this gentleman has evidence of chronic liver disease with portal hypertension, uh, and also the presence of
Hello, I think
bruising.
I lost you. Yeah, you said portal hypertension and
Sorry. And
okay.
uh, evidence of compensation.
Do you see liver cirrhosis with hepatomegaly?
Okay. Usually, liver cirrhosis has shrunken liver. However, there is possibility of having enlarged liver in cases of hepatocellular carcinoma or NAFLD. These conditions can
So
also
the
have
patient
large
is
liver with portal hypertension.
does the patient look cachectic to you?
Uh, no,
No.
I'm not able to see
Okay.
the patient.
All
I
right.
think
Okay, that's all.
you did a cachectic question.
Do you think it's cachectic?
Yeah, muscle wasting. Sorry, cachectic. Yeah.
Yeah. So do you still think that putting a muffled D or fatty liver disease is a good choice in this patient?
Yeah, not likely, but possibly not likely.
So if I give you three choice, like you're thinking of hepatomegaly with portal hypertension causing so-called hepatosplenomegaly, and there's also stigmata of chronic liver disease. Like if I give you three top choices of your
So
differential, which one will you put?
hepatocellular carcinoma,
Okay,
uh, autoimmune hepatitis,
autoimmune. Okay, you still want the autoimmune? Okay, all right. Then
mm,
one more.
uh,
You mentioned about tattoo
hemochromatosis.
marks, right? No, you mentioned
In,
about tattoo marks, right?
sorry,
Totally agree with you about viral hepatitis. The tattoo marks.
hepatitis.
Yeah, hepatitis.
Yeah.
So another one common cause of chronic liver disease that can cause hepatomegaly is alcoholic liver disease. It's alcoholic liver
Yeah.
disease. Yeah. You shouldn't actually put autoimmune. Yes, you can mention that, but not in the top three. I think for this patient, if I imagining this patient, I definitely will put HCC as my primary, and then I will put alcoholic liver, and I will put viral hepatitis. Okay, so yeah, and in terms of your presentation, right, I think you're about there, but it's just that you need to be more organized. I can see that the way you present is already I can see that you are practicing, but your presentation is not I would say not very smooth yet. You on and off stuck a bit. So yeah, so there's no right or wrong way to present. The way you present is actually from peripheral to the abdomen, and then you mention about some additional finding. Then after that, you give your working diagnosis and the functional status, the complication, and then the etiology, right? That's what you are doing now. Okay, so
Yeah.
this kind of template I would say is very useful for most of the scenario, except perhaps in the case of kidney renal endowment or a case of thalassemia. Else, I think every other cases you can just use something like that, similar. Okay, but you need to make it more I would say more slick when you talk about the finding, because jaundice, yes, jaundice is also a stigmata of chronic liver disease, but the bruises and the jaundice, these two is actually more of uh, evidence of decompensation, because bruises will tell you there is coagulopathy, jaundice can tell you that there is actually decompensation, and then ascites can also tell that there's decompensation. Okay, and then the hysteresis, no hysteresis is also important for you to mention, although it is mentioned no. I mean, you don't find any hysteresis in your examination, but yet you need to mention what is the signs of decompensation. Okay, another thing is that the portal hypertension. So in this patient, what are the signs of portal hypertension when you mention about portal hypertension?
Um, the ascites,
Mm-hmm.
and then the spider nevi. Oh no, sorry. Wait,
Okay, spider nevi is not, again, it's
no,
not a sign
it's
of
again.
portal hypertension.
Liver. Sorry,
So again,
splenomegaly,
okay,
and the ascites.
splenomegaly ascites, is that all? Is that all?
Mm.
So how about dilated veins, dilated abdominal veins?
Yeah,
Mm. And
yeah.
how about the, yeah, yeah.
This
So
yeah.
actually, this three is commonest, lah, huh? Meaning to say,
Mm.
when you talk about portal hypertension, basically you're talking about ascites, splenomegaly, and also any cavernosa or dilated abdominal veins, lah. Because the rest of it, you have to check. For example, you have to do a per-rectal examination to actually look for any evidence of melena, suggest varicose bleeding. And
Mm.
always when you present, you can see that your presentation is a bit too long. I give you a second chance, but I can see that by 2 minutes, you are you are actually right on dot, but you did not actually mention about what you want to complete your examination for. Okay, so there's two ways to complete the examination. First is when after you finish examining, press the pedal edema, dress back the patient and say thank you, and then press the alcohol. So you can actually straight away say about I want to complete my examination, or you wait until the 2 minutes. I mean the last 1 minute is up, then you mention I want to complete my examination, or it depends on examiner. If the moment you finish, the examiner straight away say, can you tell me your finding? You straight away present first. But after you finish presenting all your findings, before you actually offer your diagnosis, I think it's also important for you to complete your examination by mentioning about the vital signs, the per-rectal examination, and also hernia orifice, and also inguinal examination. So all this is actually important to mention. It's part of the assessment as well. Okay, so I think you are okay, but you can be better. So how do I do it better? Is that if this is a station, this is what I draft out, So I will mention that on general inspection of this patient, he's a middle-aged gentleman. He looks jaundiced and looks cachectic. My peripheral examination shows that there is stigmata of chronic liver disease, which is pulmonary erythema, spider nevi, loss of axillary hair, and gynecomastia. I'll just mention like that. Okay. Proceeding to the abdomen. Sorry. Before that, I can also mention that otherwise, he has no conjunctiva pallor. And then proceed to the abdomen. I noticed that that is a umbilical hernia, and it actually exacerbates during coughing. And there's also a dilated superficial abdominal veins. And my finding is actually confined to hepatosplenomegaly with a positive shifting downwards suggestive of ascites. Okay. In summary, I think this patient has a working diagnosis of chronic liver disease, as evidenced by the stigmata of chronic liver disease, as mentioned, and currently complicated with signs of portal hypertension, which is ascites, dilated abdominal vein, and splenomegaly. Clinically, he is in a state of decompensation in view of jaundice, fluid overload, in view of ascites and edema, as well as bruises, which may suggest coagulopathy. However, there is no hepatic hysteresis to suggest encephalopathy. Okay, so additionally, I noticed this patient also have tattoo marks over the arms. However, there's no palpable cervical lymph nodes. In view of all that, I think the likely etiology for this patient will be hepatocellular carcinoma with a differential of possible viral hepatitis in view of the tattoo mark seen, and my third differential can be also alcoholic liver disease. Then, if you haven't mentioned about want to complete examination, then this is the time that you want to mention that I want to complete my examination by checking this and that. It's fine, okay? But if you try to time yourself, right? If you try to time yourself when you present this, it takes about 1 minute and about 30 seconds, okay? Or even 1 minute and 20 seconds. So if you do it longer than that, so you can see that like the condition just now, like the first time when you present, although your presentation about 2 minutes plus, but actually when you talk about investigation and everything, your management actually don't have time. So you need to budget yourself some time. Make sure your presentation is concise. Make it like just 1 minute to 2 minutes time, and then you got enough time to talk about investigation and also the management. Okay. So in terms of the summary, yeah, you got any question to ask me before I proceed further?
No, it's okay. I mean, the way you summarize it, it's fine.
Yeah. Okay. So you must tell yourself that what is the stigmata of chronic liver disease, what are the signs of decompensation, and then what are the signs of portal hypertension. Okay, so you must differentiate very clearly when you present. Just like one domain, you're talking about another domain. So don't mix it up. Okay, because everything, of course, everything can be a sign of stigmata or chronic liver disease, but you want to focus those signs under portal hypertension and decompensation, for example. Okay, and when you talk about this is just a repetition. When you talk about hepatosplenomegaly, always choose the most likely etiology first. This is based on my notes, but again, there is no right or wrong way in terms of the priority. You must choose yourself. So which one is the most likely in this particular scenario? Is the patient looks obese to you? That makes the MAFLD higher in the list. Is the patient have any autoimmune features like joint problem, like vitiligo? That makes the autoimmune hepatitis higher up. Okay. If the patient looks cachexic, for example, then that makes the alcoholic liver disease, hepatocellular carcinoma, higher up in the list. Or you may also need to consider the possibility of myelo or lymphoproliferative disorder. So it's also important. Make sure that we always keep in the back of our mind. But if the patient have very overt sign of stigmata or CLD, then you should focus everything about the chronic liver disease. Okay, and then infective is always something you can tell anytime. And let's say you have only isolated splenomegaly, you will want to mention about number one as cirrhotic reported hypertension first. But let's say hepatosplenomegaly, you can also mention about that. So in those patients with right heart failure or even portal vein thrombosis, they can have hepatosplenomegaly as well. Okay, so you must actually prioritize the list of differential diagnosis you want to present. Okay, if the examiner asks you what else, until the end you cannot find any cause, you can say it's possible cryptogenic. Some patient after extensive workup cannot find any other cause, but generally we don't mention that, okay, in the exam unless the examiner asks. So when we talk about investigation, right, I always like to split my investigation. You imagine that you only have 1 minute to perform on the stage in front of two examiner, that you showing them that you can actually know how to investigate a chronic liver disease. So you again, the 1 minute must be very concise. You're talking about 20 seconds like that. 30 seconds, for example, want to confirm a diagnosis. 20 seconds want to look for the etiology, another 20 seconds, maybe you want to look for the complication. So you must make it very concise. You don't have much time, okay? So instead of mentioning all the result like that, this is not wrong, but you must mention what are the reasoning you want to do that. For example, I want to take a liver function test. I want to take a coagulation profile. For what? So must have a reason. You cannot just mention all the tests like that. So the easier way for me to present, this is very extensive list, but the easier way I want to present is actually in terms of confirming my diagnosis and severity, I will take a liver function test and coagulation profile, calculate the child bridge score, and then correlate clinically to know the patient's severity in terms of the chronic liver disease. I will order ultrasound abdomen to confirm diagnosis of cirrhosis, or even to look for any ill-defined lesions in the liver, and to confirm diagnosis of ascites. I will perform a diagnostic and therapeutic peritoneal tapping, particularly look at the serum ascitic albumin gradient, send for the culture, cell count, and also the cytology. And in terms of the non-invasive test to confirm cirrhosis, I can also consider FIT4 or a pre-scoring or even fibroscan. In terms of etiology-wise, I can take a viral hepatitis screening, alpha fetoprotein, and also you can mention 4-phase or 5-phase CT scan. And then you also can order for malignancy screening. Let's say you're suspecting this is metastasis. I will take autoimmune panel, iron study, copper study to confirm the possibility of metabolic liver disease. That will also include, for example, liver lipid profile. And if I'm thinking that this is possible due to right heart failure, echo might be necessary. And then in the situation where the diagnosis is actually questionable, then that may have a load for liver biopsy. In terms of complication to investigate, I will do a CT brain. Let's say patient have any altered mental state, that will define to exclude any bleeding, and also I will take a serum ammonia as well. And then in terms of variceal screening, we'll do a OGDS and banding if necessary. For SBP, want to take make sure patient has no peritonitis. And then for hepatorenal syndrome wise, I can take a kidney profile and also UFAM as well as the ultrasound kidney. You can mention something like that, but you can see what I mentioned is like very wrong, right? You don't have to mention every single thing. You just have to mention essential point in each domain. Because I always think that in short case, if you mention from the blood to the imaging and then to the advanced, for example, scope, it is not wrong to mention about that. But again, it make yourself less slick, and then it also hinders your thought because you must think everything as a general, because we are no longer at the medical student level. We don't carry tests one by one like that. We actually think a broader picture. So ask yourself, how do you diagnose? How do you stage the severity? How do you look for the etiology, and how do you look for complication? Okay, a lot of times you can actually go by this domain. And management, to make it short, you didn't mention anything about MDT, multidisciplinary team approach, focusing on patient counseling, education. You didn't mention anything about referral to the gastroenterology colleague for management. So a lot of things that you can actually mention. So that's why it's important to develop your own way. There's no right or wrong way, I would say. Everyone have different approach. You can mention that non-pharmacology will involve a multidisciplinary team focusing on patients' education, counseling. I will stop any precipitating factors, for example, alcohol, smoking, or even any hepatotoxic medication. I will refer patient to dietitian and may need to optimize the fluid, judicious use of fluid. And in terms of pharmaco, may need to start patient on laxative. Variceal screening may need to start consider beta blocker, not beta blocker, sorry, calipressing, let's say evidence of GI bleeding. If let's say there's portal gastropathy, need to consider beta blocker, something like that. And then for others, may need to consider annual OGDS for surveillance, HCC surveillance, and then may consider vaccination. If a patient suitable candidate for transplant, then it may need to do a necessary referral. So you can see that if you present this way, actually it's not difficult. You just need some practice. Okay, Katiban?
Yeah. Okay, got it.
You got it, yeah? Okay. So
Yeah,
I
yeah.
think I think it's enough for one case. So next, maybe we will go to the second presenter, which is Chiu. Chiu, are you there?
Yeah, I'm here.
Yeah. So I think Katiban is a first candidate to become a white rat lah, because I also not familiar. I'm just trying with this kind of style, and then, but I think everyone gets the idea. So the idea is actually to conceptualize when you examine the patient, you should actually practice the flow until you are actually not thinking what am I going to examine next. You're actually focusing not the technique, but focusing on what the sign is, and what are the signs that you want to tally up together, and you have to start thinking what how do you want to present it? Okay, so there's a lot of thought process going on when you examine the patient. It's not just elicit that you are actually done it like 1,000 times like that, perfect kind of examination, physical examination skill. The most important thing is actually during examination, you must think how you present, and then you must actually start to tell what is this, how do I present this? Okay, you must think one step forward, or else by the time when the examiner asks you what do you find, definitely you will be stuck if you're not prepared. Okay, so next scenario, I will give you 1 minute as well. Okay, Chiu, I will start now. Yeah. Okay, Chiu, are you ready?
Yeah.
Okay, all right. So just give me some time. Yeah? Okay. Okay, so Dr. Chiu, can you tell me what is your finding?
I've examined this patient on general inspection, this middle-aged gentleman. On general inspection, patient is comfortable, and I noticed there is a AV fistula over the left arm, and it is functioning with palpable thrill, and with the recent needling mark. There is no patient is not pale and not jaundice. I also on examination of the neck, that I noticed there's multiple scars over the right side. On abdominal examination, there is a midline laparotomy scar, and with the presence of retiform Morrison scar over the right iliac fossa. I also found there is a hepatomegaly, three-finger breath, and the top slit is down, and there is a palatable kidney over the left side, and able to get above the mass. In addition, patient there's no bulbar cervical lymph node, and there's a pedal edema. The auscultation of the lungs was clear. So in summary, I believe this patient is my diagnosis for this patient will be adult polycystic kidney disease. Currently with the functioning AV fistula, not in fluid overload, not in failure.
Mm-hmm. Okay. All right. So you think the primary disease is actually adult polycystic kidney disease? Then what may be the possibility that you cannot palpate any right kidney, ballot any right kidney?
It could be the reason that the right kidney is removed to for the transplanted kidney, for the space for the transplant kidney.
Okay. Other than that, is there any particular reason? Other possibility?
Other possibility could be due to right renal cell carcinoma that is removed, or it could be due to asymmetric enlargement of the adult polycystic kidney, or can be due to the hydronephrosis, unilateral hydronephrosis.
Okay. All right. How do you investigate this patient?
So to confirm my diagnosis, I would order an ultrasound abdomen and also ultrasound Doppler of the kidney to look for any stenosis of the graft and also the renal artery. And in terms of the kidney
No, sorry.
function,
So you are thinking. So do you think the graph is functioning or not functioning?
the graph is functioning.
You
I mean
think
the
graph is functioning?
no, not functioning because there is still reason needing mark over the fistula.
Okay, so you think patient is using the fistula now, so the graph is not functioning. Okay.
Yes.
So okay, how do you investigate in terms of any potential complication in terms of end-stage kidney disease in general?
Okay, to assess the complication, I would send a renal profile and the mineral bone disease profile, calcium phosphate, and also IPTH. And I would send a VBG to look for any acidosis, and I would also send for a therapeutic drug to look for any toxicity of the immunosuppressant.
Okay, time's up. Okay, all right. Therapeutic drug toxicity. So if you think the graph is not functioning, do you think patient will still be on calcineurin inhibitor or even MMF?
No.
Hmm.
Yeah.
So, but most of the time they will still be on a very, very low dose of steroid, either 2.5 to 5 mg, but they shouldn't be on calcineurin inhibitor or MMF lah, huh? So I would say well done. I would say okay, quite smooth. You got most of the point, but again you are conflicting yourself because actually you're not very sure whether the graph is functioning until I further ask you the question. Yeah, but generally you can see renal abdomen can be a bit complex, right? Do you think this case is complex?
Yeah.
A lot of things to present, right?
Yeah.
I haven't got a time to ask you. So patient also got midline laparotomy scar. So what may be the possibility of this scar for?
Yeah. Can't think of the possible causes.
Huh? Cannot think of. I thought you already said the removal of the
Yeah,
right kidney to make space, right?
I, I
That's
thought that
the
that is
that's
for
the
the transplant kidney.
yeah, but
Is it?
then the polycystic kidney, how do you remove it? So huge. You
Oh
think
yeah,
you can
yeah.
do a laparoscopy?
Oh yeah, yeah. Correct.
Yeah, it should be a midline laparotomy scar also. Huh?
Yeah.
Any other possibility for the scar?
You mean the midline?
Yeah.
Midline.
So sometimes in renal abdomen, things are not as complicated as what we think. Can be patient can have 12 scar, for example, but you need to think from the perspective of a end-stage kidney disease patient. There's only HD, PD, and transplant. So there's this component of PD. When the patient have peritonitis, sometimes it's difficult to remove the tank cough alone. They have to do a laparotomy, and sometimes have to even wash out the patient because it's a severe peritonitis. So you must keep in the mind that end-stage kidney disease patient, when you see a midline laparotomy, you need to think hard that whether the patient have a previous tank cough surgery done before, whether there's any tank cough used. So you must also check the abdomen to look for any vertical incision. I would say not vertical, horizontal incision over the periumbilical region that may suggest a previous tank cough. Sometimes can be very faint, but let's say if you cannot find any, again, you can still offer the possibility of previous removal of the tank cough possibility because of peritonitis. Okay, so this is second possibility lah. So yeah, again, I would say this case is difficult. So actually, renal abdomen, I always use a template because I feel regardless end-stage kidney disease, regardless chronic kidney disease, regardless what is the functional status, if I use the template, I realize that I can present it more concise. And then if you think that this patient has stigmata or chronic kidney disease or end-stage kidney disease, for example, at one look, patient already have fistula over the arm, and then also got IJC scar. So all this already tell you that this is nephro, It's definitely a renal abdomen. So in this kind of scenario, you can choose to present using the template because I feel, let's say you got a lot of peripheral distraction. For example, got 3 fistula, you want to mention one by one, and then for example, the scar got multiple scar, you want to mention one by one. By the time you present habis, the presentation easily will take about 2 minutes plus already, almost 3 minutes to present it, the whole thing. So it's too time consuming in my opinion. But if I do it like a concise way, okay, what I'm going to do is I will just time myself, okay, using my own template. So I will just time myself and I will tell you how long it actually use. Okay, so sir, I think the working diagnosis for this patient will be end-stage kidney disease on kidney replacement therapy. The active mode of kidney replacement therapy would be a functioning AV fistula over the left arm, as there is a palpable trill, there's audible bruits, and there's also a recent kneeling marks. In terms of past mode of kidney replacement therapy, I noticed that there is multiple scars over the right neck, which may suggest previous tunnel catheter or IJC use. There is also a right Rutherford Morrison scar over the right iliac fossa, which may suggest failing graft. However, I don't see any horizontal incisions over the paraumbilical region that may suggest any previous Tankov catheter usage. In terms of complication from the end-stage kidney disease, I noticed that there is no pallor and there is no parathyroidectomy scar or any deltoid autoimplantation scar to suggest tertiary hyperparathyroidism in the case of mineral bone disease. There is no, clinically, patient is euvolemic and no signs of uremia. In terms of immunosuppression, he is not Cushingnoid and there's no signs of calcineurin inhibitor toxicity. In terms of etiology, in view of left bilateral kidney, however, there's no right bilateral kidney, I will still put my top differential to be adult onset polycystic kidney disease. The differential can be due to left hydronephrosis or left renal cell carcinoma. Additionally, I noticed that there is a midline laparotomy scar, which may suggest possibility of right nephrectomy in the background of ADPKD. Okay, that's all. So it takes about 1 minute and 30 seconds just for my presentation at this kind of conciseness. So you can see that if you present from peripheral to the abdomen and give your final summary, that will easily take about 2 minutes and 30 seconds. You can see that. So that's why for renal abdomen, I still prefer to use this template because I feel this template will actually get hold of myself that I will not miss anything important for renal abdomen. Okay. Do you think you can present it this way?
Yeah, I think I need more practice.
Yeah. So the idea is actually the message I want to carry across tonight is not to show how good I'm good at presenting. It's basically I want to tell everyone that with enough practice, you can do it maybe better than me as well, because I'm no longer it's like almost reaching 2 years already for passing exam, right? But again, the idea is actually for you to practice, and then not just when you go to examine a patient in the clinical setting, it is not just for you to appreciate the sign. You must practice to someone, you must practice yourself. And if no one is around you, you just record your own voice, okay? So you record your own voice and present, and then you listen back how is your presentation, because you need to have a very smooth and concise presentation. Okay, in exam you are preparing for a war. Okay, if you want to win a war, then you definitely need to have a best equipment, and then you have prepared. Okay, so all these things you can actually prepare before you even examine the patient, because if all this template is inside your brain, right, the moment you examine the patient and you get the positive sign, you are just slotting out all the sign into your template only, and then you just present out like that. Okay, so that is the message I want to tell everyone. And in terms of this is the template. Yeah, if let's say you don't find any obvious etiology to suggest the primary disease of end-stage kidney disease, always go by the commonest one. For example, if you cannot find anything else, so take a good look at the periumbilical region to look for any insulin injection mark that may suggest diabetes on insulin. And we know that the primary cause, about 58% in Malaysia, is due to diabetes, diabetic kidney disease. Another about 18%, last time used to be 20, but now it's actually lower. About 16 to 80% is due to hypertension. Another 5% is due to GN, including lupus nephritis. And adult polycystic kidney disease is also quite common in the Western, but in Malaysian, actually the incident you're talking about 0.5 to 1%. And then drug autoimmune and then post-renal like obstructive uropathy is actually less than 1%. No? So if you want to go by etiology, you can present as such, the commonest being diabetic kidney disease, followed by hypertensive nephropathy, followed by glomerulonephritis, including lupus nephritis, and then adult onset polycystic kidney disease, or even like drug-induced nephropathy. Yeah, you can present like that. Okay, and if patient have evidence of renal transplant, whether fail or not fail, you should also mention about the complication, because some they already on immunosuppression for long before they eventually fail. So you also need to look out for any signs of immunosuppression, over immunosuppression, like for example, gum hypertrophy, hypertrichosis. But in this patient, my focus is not on that because I think it's already failed. With the fistula functioning and vessel needing, it tells you that the graft have failed. Some patient may come with 1 transplant, some patient may come with 2 transplant. The idea is you need to tell yourself whether what is the active mode of dialysis, or what we call as active mode of kidney replacement therapy. Which one is the active one? Because you will have 3 together, for example, then you need to decide which one. Okay. All right. So bilateral kidney for unilateral for your case, yes, can be ADPKD with asymmetrical enlargement, or is already removal to give space for transplant. For this case, it can be hydronephrosis unilateral. Renal cell carcinoma is yes. Usually perirenal hematoma won't be there, because in the exam, if it's there, that means we are not doing anything to address the hematoma. It's not fair, right? And then this renal hypertrophy with post-contralateral nephrectomy is quite rare. This is something that you cannot find any reason. You just want to give a reason, then you can. But I would generally would not include that. How about bilateral kidney? So definitely you want to put adult onset polycystic kidney disease, but don't forget that one triple lean down and also tuberous sclerosis complex also can cause bilateral kidney enlargement. And don't forget about diabetic nephropathy. It can be bilateral, but usually not very huge. Can be amyloidosis, can be bilateral obstructive uropathy, can be bilateral renal cell carcinoma. Okay, so these are all the possibility. And then how do you investigate and manage? I think there's no right or wrong thing. So this again just a template. This is like for CKD to end stage kind of presentation. But again, you need to know what is the diagnosis for this patient. Like for example, this is someone is already end stage kidney disease. There's no role for you to really talk about protein, send the urine quantification and stuff because patient is already end stage kidney disease. The focus is actually to look for complication. So you're talking about anemia, CKD, MBD. So you need to check the iron storage. You need to check the fluid blood count, the fluid blood picture to exclude any hemoglobinopathies. You need to make sure the iron storage is adequate. And then you also need to make sure that the mineral bone disease perspective, the calcium, the phosphate, IPTH, and sometimes the vitamin D, whether it's adequately replaced. And then in terms of the cardiorenal, whether there's any patient have any concomitant heart failure, you want to look for any echo, x-rays. So all this is something like very practical. We do it day in, day out, but the exam, we don't know how to present it. Okay, so you need to think as if you are just present it as if you are in a walk round. You tell yourself how to look for complication. And then if let's say you're talking about CKD and this patient have no evidence of kidney replacement therapy, but there is a bilateral kidneys, and you think this is adult onset polycystic kidney disease, then the management and investigation will be very different because your target now is to prevent or so-called delay the CKD progression. And you need to confirm diagnosis for adult polycystic kidney disease. Then yes, you need to do ultrasound, ask for the family history. Okay. Another thing is actually you need to know the kidney function, and here comes the role of telling about the renal function, the blood gas, and also the electrolytes. Okay, and also work out for other etiology. And then only then you want to talk about delaying the progression. For example, under the management, you may want to talk about the non-pharmaco, and then the blood pressure control, sugar control, for example, antiproteinuric management. Okay. And then also in ADPKD, particularly important, you want to talk about tolvaptan. Okay, so tolvaptan is actually what is the indication of tolvaptan. A lot of examiners may not know in detail, but generally not every patient fulfills the criteria to start tolvaptan. Okay, tolvaptan is not for all. Tolvaptan is generally between the age of 18 years old until 55 years old, and then those patients that manifest features of rapidly declining kidney function. Different center, different country have different cut off to this. Okay, how many percent, 3 to 5, for example, per year drop in eGFR, things like that. But no need to know about the criteria. The idea is to make it a general way. If patient has rapid progressing decline in the kidney function, the patient is within the age of 18 to actually 55 years old, and then if the patient belongs to the Mayo classification of 1C to 1E, because this 1C and 1E meaning to say that it's actually a calculation, a scoring based on the either kidney MRI or the CT scan to calculate the volume of the polycystic kidney, and then look at the progression, because this actually is a validated score to decide how fast the kidney can deteriorate and whether they need treatment or not. And generally, once we start the Toritan, we should actually continue until they develop become end stage. Okay, so there are certain things that actually needs to manage as well. For example, CKD anemia, we need to talk about the iron supplementation, the EPO, and the HIF inhibitor, the latest still in the study, and then the mineral bone disease, for example, the phosphate binder, calcium based, non-calcium based, and then vitamin D analogs, calcium mimetics, and then got metabolic acidosis, then you may want to give sodium bicarb. So all these things is like very straightforward. But again, there's no right or wrong way. It's depending on how you want to present it. Okay, all right. Xiu, you got any question? Are you still there?
Can you hear me?
Yeah, I can hear you.
I think in my past experience of the exam,
Mm.
the examiner straight away asks what's your finding and how do you investigate this patient. Actually, for me, I think not much time for me to present so detailed. So what is
You
the
don't need to
best
be go
way?
detail. You just need to go by what the examiner asks you. So you need to be a bit flexible. Meaning to say, examiner asks you what, then you answer the examiner. You don't need to go by your own template, like I would say. Yeah. So
Okay.
continue your question.
So so I can just okay, I know what you mean. Okay, okay.
Yeah. So let's say examiner asks you, so what is the diagnosis? So you can still follow your way. Like for example, in this patient, I would say my working diagnosis for this patient is end-stage kidney disease with on kidney replacement therapy. I will show you mention that, and then I will just go with my presentation. But sometimes, for example, in a for example, in the first case, in the hepatobiliary station, so the examiner asks you what is the diagnosis, and you are stuck whether I should present peripheral by positive sign first. So it's okay if you want to tell the examiner your sign first, followed by diagnosis, they won't fault you because according to the examiner's marking scheme, after the physical examination component, they need to know what is the sign that you detect first, and then only then they can go for diagnosis. So certain examiner may straight away ask you what's the diagnosis, but again, you can still continue to present, but try not to irritate examiner by presenting a lot of negative findings. You want to focus on the positive finding, and that's why when you present a peripheral examination to, for example, abdomen, you need to be very concise and just hit to the point. Okay, so yeah, and then sometimes examiner may ask you different question, and don't be worried if let's say examiner did not ask you how do you investigate, how do you manage, because the critical judgment component does not always necessarily include the component of investigation and management alone. So the examiner can ask you, for example, I asked you, so what are the working diagnoses, what are the possible differential with the unilateral bilateral kidney in this patient. So this is also assessing the clinical judgment. It's not necessarily mean that you must go to investigation, you must go to management, only then you can get full marks. It doesn't work that way. As long as examiner thinks that your clinical judgment is good and able to answer most of their question, they will usually give you full marks. Okay. Some examiner may give you half mark, I don't know, but generally if you can answer that question, there's no reason why they shouldn't give you. Okay. All right. So don't be worried. But again, our baseline is when we walk into the exam hall, when we present to the examiner, our baseline is we must already know how to investigate this kind of condition and then how to manage. It's just that whether you want to present it out or that depending on the scenario. Okay.
Okay.
All right. So next one will be let me just check. Okay. So next one will be Wu, right? Wu, are you there?
I am here.
Yeah, okay. So you are ready? I'll give you 1 minute, and then if you are ready after that, after 1 minute, then we will start. Is it okay?
Sure, sure.
Okay, all right. So we start now. Okay, Wu, are you ready?
Yeah.
Okay. So, Dr. Wu, can you tell me what have you found in this patient?
Okay. This patient, I believe this patient has a chronic hemolytic anemia. It is evidenced by the presence of jaundice and hepatomegaly. How, uh, However, there's no splenomegaly. There's also frontal bossing and also malaprominence suggestive of extramedullary hemoptysis. There's also evidence of pulmonary hypertension with loud P2 and also parasternal heave. My differential diagnosis includes hereditary hemoglobinopathy, which is in our case is thalassemia, and some other causes, elliptocytosis, spirocytosis. Less likely causes includes secondary hemolysis, such as SLE and rheumatoid arthritis.
Mm-hmm.
I will further investigate this patient by performing a full clinical history and also examination of the cardiovascular system and also endocrine system.
Okay.
Uh,
So, probably I will just stop you for a while. So, I want to know what are the complications that you detect in this patient?
there's a evidence of diabetes mellitus with finger pricking marks and also recurrent phlebotomy, which indicates a patient require transfusion, multiple transfusions.
Okay. All right. So, do you think patient is transfusion dependent
Yes.
thalassemia?
Yep.
For example. Okay. And do you notice there's any scar in the abdomen?
Oh yeah, there's a subcostal scar which indicates a cholecystectomy in chronic hemolytic.
Cholecystectomy. This is a left subcostal scar, right?
Oh, that's subcostal splenectomy. Sorry.
Okay. So if you think this is splenectomy, what might be the possible reason for that?
In this case, I would suspect a hypersplenism for thalassemia.
Any other possibility?
The other reason for a splenectomy includes splenic trauma and also splenic infections.
Okay. How about in thalassemia?
In thalassemia, usually splenectomy is indicated when it's symptomatic, causing pressure effects, or there's an increased hemolysis.
What does increased hemolysis leads to?
Iron overload.
Okay, all right. So how do you investigate this patient to confirm the diagnosis?
I will further investigate with a full detailed history, particularly in family history, cardiovascular examination, and also endocrine examination. I would
How
like
about
to confirm
investigation?
investigation. I would like to confirm my diagnosis by electrophoresis, FBC, and also FVP. I would then need to screen for complications of thalassemia, including iron overload. I'll search for LFT and a bedside ECG, echocardiogram, and also iron study.
Okay.
Then I would like to check for the endocrine investigation, the anterior pituitary, TFT, prolactins, and also FSH, LH.
So how do you manage a patient, for example, in this patient, you think is transfusion dependent thalassemia?
In transfusion dependent thalassemia, we how to manage? Okay. We regularly transfuse and we correct the iron overload with iron chelating agents.
Okay.
And monitor for the side effects of the iron overload.
Okay. All right. Thank you. So
yeah.
time's up. 4 minutes already. Yeah. Very good. I would say you are very smooth, very fluent. Yeah, but again, the investigation. I'm looking for that magic word that you didn't mention. You mentioned that you want to work out for the iron overload, right? You mentioned about iron study, echo. You mentioned about what? What else? You mentioned about the iron.
I think that's what I mentioned.
Yeah, but I believe you managed thalassemia patient before, right?
No.
Oh, you didn't manage before. Never mind, it's
Yeah,
okay. But there's one special test that you definitely need to order every year. It's an MRI T2 star. Do you heard about it before?
Yeah.
Yeah, MRI T2 star want to look for liver and also the cardiac iron loading. whether patient is really overload. And then because for this kind of patient, definitely a patient that underwent splenectomy, and most of the time is because of the high iron overload. So this kind of patient, you must make sure you optimize the chelator. And also the goal is not to transfuse regularly. The goal is actually to transfuse according to the patient needs, and to optimize the chelation, and also to, yes, like what you say, to address and treat all the complications associated with iron overload. Okay. Yeah, I would say you're very prepared for exam. If you can present like this in a real exam, definitely I think you will score well. Okay. But you missed the scar. Is it because you forgot about the scar?
Yeah, I actually forgot about the scar.
Yeah, so I don't know whether giving every candidate 1 minute is enough to read through the stem, but I think it's not difficult. So that I just want to go back to this stem, because since I think you present quite well, I don't have many things to add on. I just want to highlight that if you encounter any thalassemia patient, like very clear-cut thalassemia, or even possibility of chronic hemolytic anemia kind of patient, you must make effort to actually auscultate the heart. Okay, it is not acceptable, or I would say it's not complete, that if you examine a thalassemia patient in the abdomen station without auscultating the heart. And the reason why I put here cardiovascular system, you just actually look auscultate 2 point only, just putting at the upper left sternal edge to listen for any loud P2, and then at the tricuspid region to listen for any murmur. Basically, you just need to do this 2 point only. So it's actually very short, but it's something that we should do, because thalassemia, this is also how you assess for complication. Okay, so you can see that when I prepare this scenario before I think I just prepared yesterday. So when I type out this scenario, this is exactly how I visualize a patient when I examine the patient. First, I look at the patient. I tell myself whether this is a young patient, middle age, or elderly. And then I look at the body build. Is it like thin, malnourished, or is it well built, obese? And then whether there's any stigmata. For example, in this patient that looks like thunderbossing and malar prominent, that will tell me this is extramedullary hemopoiesis. And then I also look at the skin, that is a slate gray pigmentation. And then I also look at joint deformity. So in my real exam, my thalassemia patient that I got in exam actually got tophi. I was very shocked, because usually I don't see tophi in thalassemia patient, but that patient, I don't know what is that. I thought it's like some bone growth or something, but I still mentioned that can be pseudo-gout. But it can really be pseudo-gout. Thalassemia is associated with that. Anyway, there's also joint deformity. There's also some finger prick marks, no clubbing, no hysteresis, no pulmonary edema. Basically, these three is to tell you there's no stigmata or chronic liver disease. So this is something that when you examine the patient, when you go through, when you're checking the patient hand, you just not to ask the patient to put up, put down like that. You're actually looking for all this, and then you are trying to present it in a way that you can summarize the things better. And then you also notice there's frequent cannulation marks. Certain patient may have a PICC. Let's say it's like maybe less than 2 weeks transfusion. A lot of times they will have some central line. Occasionally, if transition for pediatric, they may even have a chemo port, but quite rare. So tinge of jaundice and pallor is something very important, because if you see tinge and pallor jaundice with hepatosplenomegaly, the first diagnosis you need to give is actually chronic hemolytic disorder, and predominantly thalassemia commonly. And then no spider nevi or loss axial hair. Again, this is actually a stigmata of chronic liver disease. This is how I visualize the patient as I go through the examination. Then after that, I will go to the abdomen. I will see that there is a multiple needle marks at the pre-umbilical region. This can suggest two things. It can either suggest insulin use, or it can suggest dextroamphetamine injection. We don't know, because it's not written, or we cannot. Usually, if they are using the dextroamphetamine, they will usually put the infusion at the bedside, so it's easier for you all to see. If not written, we cannot assume, okay, if it's not there. And then transverse scar over the right subcostal. So it's my mistake lah. I actually write right subcostal. Actually, I want a left subcostal. Sorry for that. Okay, and then hepatomegaly, four-finger breath, and then trough space is actually resonant, and then no shifting downwards, no vertebral kidney. And then after that, I press the leg, and then I go to ask patient to sit up, examine the lymph nodes, and then I quickly auscultate the heart for loud P2 and also soft systolic murmur at the tricuspid region. So that's how we present. Okay, so just omit me. I need to put this as a left. Yeah. Okay. So I think how Wu present is actually quite good. he has his own template, but generally to make it complete, this is how I'll present. So I will actually say that, sir, I think the patient has a working diagnosis of chronic hemorrhagic disease, and most common being thalassemia, as evident by the thalassemic phases, anemia, and dish or jaundice. In terms of complication, I can see that there is an extramedullary hemopoiesis evidenced by hepatomegaly, frontal bossing, and malar prominence. And there's also complication from hypertransfusion. From the skin itself, I can see that the patient has severe pigmentation, and patient may also have diabetes because of the finger prick marks, as well as the possibility of insulin injection marks. However, there's no loss of axillary hair to suggest hypogonadotrophic hypogonadism, and there's no stigmata of chronic liver disease to suggest secondary hemochromatosis. In terms of cardiovascular, I can appreciate that he has a pulmonary hypertension with evidence of tricuspid regurg with a loud P2. And then I also noticed that there is also some joint deformity over the bilateral hands, which may suggest pseudogout in association with thalassemia. In terms of complication for chelation, I don't appreciate any bedside desphosphamic infusion pump, and therefore I would like to check the patient with the patient medication list for any oral chelators. In terms of chronic hemolysis complication, I think patient has a transfusion dependence in view of multiple cannulation marks seen. And there's also a left subcostal transverse incision which may suggest splenectomy, and that may suggest severe iron overload or hypersplenism. And otherwise, there is no scar over the right subcostal region to suggest any cholecystectomy. Okay, that's how I will present. Of course, this is like very complete. In the real exam, you may only present like 80% to 70%, but that's good enough. The idea is you need to practice. And if you're not sure that whether patient have thalassemia or not very classic, you may choose not to present using this template. You can just go back to the basic. Go for the general inspection, peripheral, then go to abdomen, and then present the finding, and then you only offer diagnosis. It's totally all right. But if you're sure that this is thalassemia and this is really thalassemia, and you got found all the complication, and you want to present this way, I would say it's more concise and also more professional. But again, it carries a risk, because it may not turn out to be thalassemia. For example, sometimes it can be due to hereditary spherocytosis, for example. It is still possible, but again, that's not wrong if you present as such. So that's why if you don't want to commit yourself, you can say, I think this is a chronic hemorrhagic disease with evidence of anemia, jaundice, and for example, hepatosplenomegaly. In terms of complication, then you continue like how you present. Okay, so I think this is just a rough idea. I hope everyone will learn something. And generally, yeah, this is again the same repetition. This is just a default template that I like to use last time. So I will talk about transfusion dependence in terms of chronic hemolysis, cholelithiasis. I will look hard for any scars, and I will look for peripheral, especially for chronic stigmata or chronic liver disease. Like some patient may even have spider nevi and such because the liver is already hemochromatosis gao already. They may really have stigmata of chronic liver disease. So this kind of patient, look hard at the patient, make sure that you are talking about this is actually hematoabdomen instead of like hepatobiliary kind of abdomen. It's not wrong if you present either way, but again the focus will be a bit different, because if you're talking about thalassemia, you're talking about other complications. But if you're talking about this is chronic liver disease and the cause is chronic hemolytic anemia, then you actually did not touch on other complication that you should mention for a thalassemia patient. Okay, but either way you can still score, just that maybe not full marks. So the investigation, I think he has mentioned most, but the important thing I want to highlight is always, if you cannot remember all the other complications that you want to order for the thalassemia patient in terms of investigation, mention about access the iron store, mention about MRI T2 star. The examiner, the moment examiner hear this, I think they will give you marks already. Okay, MRI T2 scar is the most important thing. And osteoporosis risk is quite high. Make sure to order a bone scan as well. And then management, yes, iron chelation, bone protection, and this kind of patient, I mean, I'm not expecting you to mention that, but if you think about it, then you may also want to mention about prophylactic penicillin B because of the splenectomy, and also assess the compliance and stuff. Okay, so I think that will be it for abdomen station. So anyone have any question before we proceed with respi? Okay, unmute yourself. If no, then we just proceed now, just to save time, because I don't want to occupy too much time as well. So let me just check. So next is actually Lo. Lo, are you there?
I'm
Oh,
here.
you're
I'm here.
prepared already. Okay, so you are ready, yeah? So I will give you 1 minute. You read through the scenario, and then after that, you will just present as you go in the exam. 4 minutes. Okay, all right.
Okay, sure. Yeah.
Okay, Lo, you ready?
Okay, sure. Right.
Okay,
So
all right. So Dr. Lo, can you present the finding that in this patient?
I would like to complete the examination by checking the blood pressure of this patient and also by examining the sputum port. So I examined this patient. The patient has a finger clubbing, and so I noted there is some deformities over the joint, which is a swan neck deformities. However, there is no any signs of peripheral or central cyanosis, and patient is not pale. The trachea is centrally located, and there's no obvious scars seen over the anterior or lateral chest wall. On the chest is actually expansion is reduced bilaterally, and the finding is more confined to the bilateral lower and middle zone, with reduced in reduced in breath sound, and also is dullness on percussion, and cause capitation that alters with cough and reduce in vocal resonance. And on the same time, the patient has a loud P2 and also with bilateral PDA edema, but there is actually no palpable lymph nodes seen. So in summary, this patient could have a bilateral bronchiectasis complicated with a pulmonary hypertension. And the cause of this bronchiectasis could be also due to, in this case, will be due to a rheumatoid arthritis, leading to pulmonary fibrosis and eventually lead to bronchiectasis, or could be due to bilateral post-infective bronchiectasis as well. Or
So other than rheumatoid arthritis and then infection, any other possible differentials?
could be also due to drug-induced bronchiectasis, fibrosis leading to bronchiectasis. As this patient could be on methotrexate, as the patient is had deformed joints. So how I would like to investigate for this patient is, first of all, I would like to do a lung function test to see whether this is a restrictive or obstructive pattern, and to do a chest radiograph to see any air bronchogram, and to confirm my finding, I would do a high resolution CT scan of the lungs, and I would like
What are the features that you expect to see in a HRCT?
Okay, could be the patient has any honeycomb appearance in this patient, or tree in bud.
Tree in bud is not classic for bronchiectasis, but any other features?
Features, sorry, I'm not sure about that.
Okay, never mind. So other than that,
I would like to send for any inflammatory markers as well to look at the ESR and CRP, and also to send the sputum port for any culture and sensitivity, and also to screen for TB as well in this patient. So how I would like to manage this patient is, I would like to involve a multidisciplinary team, counsel the patient and educate the patient regarding the disease, and also advise for smoking cessation if the patient is a smoker, and for pulmonary rehabilitation, and refer him to the respiratory physician in this case. And also if for pharmacologically, I would like to treat the patient according to the etiology. If this is due to rheumatoid arthritis, I will like to also refer to the rheumatologist to optimize the control for the rheumatoid arthritis, probably alternating drugs for him. And if this is caused by infection, then we'd like to treat the infection with antibiotics and also to counsel the patient for annual vaccination.
Okay, so you mentioned about the bronchiectasis management. So is there anything in terms of medication that you can give the patient?
Probably the patient could benefit from inhalers as well.
Okay, all right. Hands up. Yeah, well done. I think you are very smooth. But just one tips is that you must wait for examiner before you present. Okay, for example, I didn't talk about how do you manage first, so you have to wait first. You don't straight away jump that. In terms of
Okay.
management, you straight away go there because certain examiner they are very senior and they will feel that this is a bit offending lah. Some
Okay.
to certain extent lah. So you just pause first and listen to what they want to ask you. Okay.
Okay.
So sometimes, like I say, you always answer the examiner question. It's not that what we want to present, but instead what they want from us. Okay. So I think you are very well versed, very well versed. I would say that if you can present like this in exam, definitely you have no issue. But the question is that you must able to appreciate all the sign. Huh?
Okay, sure.
So okay, yeah, because in this patient, right, if you examine in real life, you'll be wondering yourself that this is a rheumatoid arthritis. Can this be more like pulmonary fibrosis instead of bronchiectasis? You know, because we know that RA usually is ILD, RA associated ILD is actually more common, but sometimes can also have bronchiectasis. So you need to tell yourself that. So the difficulty in this kind of scenario is actually to differentiate whether this is a bronchiectasis or this is a fibrosis. Okay. But because this is a virtual practice session, I already give you all the signs. After we cough and everything, you are like damn sure that this is bronchiectasis. That's why you can present as bronchiectasis, right?
Yeah.
So in real life, how do you differentiate between bronchiectasis and pulmonary fibrosis from examination?
From examination itself, first is by like auscultation. Normally, if pulmonary fibrosis will be a fine and inspiratory crepitations. And also, I would like to look for any other signs of like systemic sclerosis.
No. Just for physical examination only. So you mentioned about the crepitation nature. So you say fibrosis is actually fine and inspiratory crepitation. Okay. How about bronchiectasis? The crepitation is caused, right?
Oh, yes, yeah.
Yeah, but actually, to be honest, end-stage fibrosis, the advanced stage of lung fibrosis can also present as cause crepitation. So how do you differentiate in terms of the crepitation nature?
Sometimes by cough, seeing whether it changed with the, by cough induced.
Yeah, to be fair, right, this elder with cough thing is very subjective as well, depending on which region that you cough and depending on which mucosal plugging that at that particular time is, where is it? Because if the mucosal plugging is not there, you ask the patient to cough with or without coughing, it actually does not change, but it does not really exclude bronchiectasis. So I would say that the most obvious way to differentiate is ask patient to cough first before you even examine the patient.
Okay.
So stand at the end of the bed, after introduce yourself and everything, and then just ask patient to cough, and then listen to the cough nature. If the cough tell you that like very very chesty like that, then this is already telling you that looks like bronchiectasis. Okay, and it's like very dry kind of cough, and that will tell you more to fibrosis. So this is the first thing before you even touch the patient. Second thing is actually, yes, you can listen to the crepitation nature. A lot of times when you're talking about bronchiectasis, so bronchiectasis is actually permanent and thickened airway. So meaning to say all the small airway will be thickened as well. So when you inspire until the end, actually when you inspire until the end, you should actually open up all the small airway. But in bronchiectasis, actually all the airway cannot open up already. So actually the crepitation, the cause crepitation that you hear, usually actually they are very dampened towards the end inspiration. Meaning to say you like that before they exhale out. As opposed to pulmonary fibrosis, and in the severe pulmonary fibrosis cases, their crepitation is definitely can be very coarse one. It's no longer that fine crepitation. So, but one thing for pulmonary fibrosis is that when you listen to the crepitation, it can be very coarse. It can start early, it can start mid, it can start end inspiration. But one thing you realize just before the exhale, at the end inspiration, the crepitation will be very, very loud. Okay, so this is another clue to differentiate. That's why when you escorted, you need to listen a bit detailed. Only you can differentiate both of them. And there's also a third thing. I mean, both also got clubbing, both also got crepitation. And there's also a third thing that I'm going to mention later lah, because I got one chart. So, okay, so I just want to go through. You can go what you present, but I think there's still certain point that you can improve. For example, instead of telling the patient, this patient has clubbing, I would actually take a step back. I would say that on general inspection, this is a middle-aged, thin-built lady who is not in respiratory distress or needing any oxygen therapy, and she has a wet cough. I will just stop at that first, okay? Because that will tell you that, okay, this is I'm selling this as a bronchiectasis, okay? And I'm telling you that actually she looks thin, she's not in distress. This is the functional state first, okay? And then on my peripheral examination, there is a digital clubbing, and there's no evidence of CO2 retention. And otherwise, she's not pale, not jaundiced, and there's no cyanosis. Her trachea is central. If you present like that, definitely tell everything already from the peripheral examination. And most important thing in respiratory system is you cannot afford to miss the tracheal finding. You must examine for it, you must present for it. If it's central, you say central. If it's deviated, you say deviated. So you must not miss the trachea in respiratory, very important. And then after that, my lung examination finding is actually confined to the bilateral lower to middle zone, in which there is a reduced chest expansion bilaterally, down on percussion, reduced breath sound. However, there's a lot of coarse crepitation which after we cough. And there's also reduced vocal resonance at that area. Functionally, there is evidence of cor pulmonale because there's a loud P2 with pedal edema. My working diagnosis for this patient is bronchiectasis, and the likely etiology for this patient would be rheumatoid arthritis in view of classical rheumatoid changes over the hands. And I want to offer my differential diagnosis to be psoriatic arthritis or even possibility of SLE, because it can also present as a Jacob arthropathy. Okay. Additionally, you have mentioned something additionally, because sometimes when you go follow your own template, you may not appreciate any other thing that you want to mention. You also notice that there's this BCG scar and there's no palpable cervical lymph node. Okay, that's how I present it. Okay.
Okay. Right.
So if you just more like fine tuning. I think your presentation is very smooth and you're definitely ready for exam. It's just that you need to be more, I would say, take a step back. Always, sometimes if you prepare something too OCD, then you will actually tunnel vision until we just care about the minor details. But sometimes you also need to zoom out a bit and you look at the patient as a general. What does the patient tell you from beginning? And then you mention that first, okay?
Okay. Right.
All right. So this is just like what I want to mention just now. So let's say you encounter a patient that is both CLAPS and also CRAPS. So usually it's just these two lah, bronchiectasis or pulmonary fibrosis. So again, I highlighted these three things. Is the cough, crepitation, and also the end inspiration. So both will have clubbing, both may or may not have scar, both may or may not have tracheal deviation, and both percussion and chest extension will be reduced and down. Okay, so these three things, like I say, the most important screening thing is for any respiratory station is actually you ask patient to cough first before you examine him or her, and then you also count for the respiratory rate for about 10 seconds while you are observing her to cough. I mean, while the patient is coughing, you shouldn't count the RR lah. But before you count the RR or after that, you do it separately lah. But it shouldn't take more than 15 seconds. It's okay. I know respiratory is very stressed to complete both front and back. Generally, I encourage everyone to do front and also back. And you time yourself to complete the front examination by 2 minutes and leave the remaining 4 minutes at the posterior, including the lymph node examination and also auscultation or loud P2 if indicated, and the pedal edema. So if you do like that, if you time yourself, you do the anterior not much. Actually, you just chest expansion 3 times, percussion 3 times, auscultation times 2, because one is for breath sound, another one is for vocal resonance. Actually quite fast only. But the 2 minutes also include the peripheral examination, which is also not much. You just ask patient to show you the hand, and then to lift up the hand, and then to look for any other scar or any BCG marks, and then go to the eyes, go to the mouth to look for cyanosis or not, and then basically that's all. Okay, so that's why you shouldn't take more than 2 minutes if possible. Okay, so yeah, so again back to this question. So cough should be very chesty, very copious in bronchiec, and very dry, or very minimal amount in fibrosis. Crepitation should be always caused in bronchiec and after we cough. Fibrosis sometimes is actually fine in early stage, but can be caused in the late stage and usually it does not alter with coughing. And end inspiration is the one that I mentioned because airway is already dilated permanently. So those airway cannot be opened already. So usually it's like a lao hong like that. I mean the gas when you breathe in, it actually gets dampened and it still get louder. Okay. So in terms of etiology for bronchitis, it's also good for you all to actually have it in your mind. So you want to say localized or like what we call diffuse bronchiectasis. So don't mention about bilateral bronchiectasis okay. So most of the time bronchiectasis, yes, can be localized. Usually we use the term localized or diffuse. We don't use unilateral or bilateral. So if you're talking about localized bronchiectasis, it can be obstructive cause, can be intraluminal, like foreign body, like chronic aspiration, or luminal, like mitotic lesion of the lung, obstructive airway disease, extraluminal, like nodal compression. If it's infective, then you mentioned about TB, ABPA, childhood infection, immunodeficiency, hypogammaglobulinemias, common variable immunodeficiency, acquired like RVD, autoimmune causes and syndromic causes like cystic fibrosis, primary series dyskinesia, even yellow nail syndrome. So when they talk about investigation for bronchiectasis, you still need to go through all this workup. Okay, you must divide yourself as infection. Yes, you want to confirm the diagnosis of bronchitis, no problem. But after that, to look for etiology, you should mention all that. Infective screening that will include you can also consider sending a sputum culture, sputum AFB, and also the TB culture, and also send for serum aspergillus, for example. And then immunodeficiency, send for serum IgG, IgA, IgM, and then infective screening, including HIV tests, autoimmune screening, and also CFTR. Let's say you suspect for cystic fibrosis, can consider to do a screening swab test, followed by CFTR mutation study, and something like that. And then if you're talking about pulmonary fibrosis, then you always try to tell yourself whether this is a more like upper loop predominant or lower loop predominant. If it's like a apical or basal, right? Apical is like the pneumonic scar or ratio. So silicosis, sarcoidosis, co-vocal pneumoconiosis, chronic eosinophilic pneumonia, histoplasmosis, hypersensitive pneumonia, ABPA, blah, 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 blah. I think everyone can go through that. But the ideal important thing I want to highlight for rheumatological condition, connective tissue disorder, most of the lung fibrosis in CTD is always lower loop predominant, except two, which is psoriatic arthritis and ankylosing spondylitis. Okay, this is something important. The rest of it, I think everyone can understand. TB definitely upper zone because you know that cavitation likes more oxygen in the upper loop, and then the rest of it like ratio, rheumatoid arthritis, SLE, Sjögren, myositis, ILD, idiopathic pulmonary fibrosis can be due to UIP or NSIP, or even drugs. Those are the possibility. Okay, all right. Any question from the audience?
So I got a question. I mean, will there be a case like really come out like lung transplant, and what will be normally the finding?
Lung transplant, you shouldn't expect anything lah. Just a scar only.
Or just a scar? So I mean the finding is normal.
Yeah, I mean patient may have a lateral thoracotomy scar, or may even have a clamshell incision scar. That will be the telltale sign. Sometimes any intervention to the lung can cause a lot of this pleurisy, or even pleural thickening, and even what we call as pleuritis or pleurisy. So sometimes those kind of patients you may able to hear fine crepitation over the lower zone, but generally they are not fibrosis. You should not hear like very diffuse over the whole left lower zone of the lung. So it should be just like crepitation, very minimal like that. But generally, it's very, very normal examination. You shouldn't expect a lung transplant patient to be like collapse a consolidation . And again, it depends on the etiology as well. So what is the etiology of the lung transplant when you see the scar? You must tell yourself, in Malaysia, the program is starting, but I don't know whether we have any patient that already go through that. But if you want to prepare for the worst, so you need to tell yourself, in overseas, the most common lung transplant indication is still cystic fibrosis, and followed by those, for example, end-stage lung fibrosis patient or even bronchitis patient, and also those advanced COPD patient. So those are the common ones. So you may want to screen through, and then the peripheral stigmata will give you some clue. For example, the patient got clubbing, very significant clubbing. So maybe you're thinking that maybe the previous etiology is like bronchiectasis or fibrosis, or even cavitation, like talking about suppurative lung disease like lung abscess, or even empyema that's so bad and they need to do a lung transplant because lung cannot function already. You're thinking about that. If let's say this is like someone that's quite healthy, you don't find any other obvious clubbing or any nutrition status is also quite good, then you are thinking that this may be just due to, for example, COPD, for example, some other rare causes lah. Usually for cystic fibrosis, they should give you more clues. Like for example, they may give you some medication. They may have some bedside devices like the acapella devices or even aerobica to actually tell you that the patient may actually need to expectorate the sputum even though after lung transplant. And then sometimes the patient may also looks a bit dysmorphic. So you need to think about all that. But generally it's really rare. I don't think we see any of these cases in the recent years. But don't be worried. Just go by your findings. You shouldn't go too far if you, let's say you actually appreciate the sign correctly.
Okay, all right. Thanks.
Okay, all right, thank you. So I think the next candidate will be sorry, my voice is quite bad. Will be Zian. So Zian, are you there?
Yes.
Yeah, I think your voice is too soft. Can you
Hello. Yeah.
yeah, can you hear me?
Yeah. Yes.
Yeah, this tone is better. Okay, so I will give you 1 minute as well. Okay, so I want you to read through read through the slide, just like how you examining the patient. And then by the time is up, I want you to present like you are in exam. Okay?
All right. Sure.
Okay, so I will start the timer now. Okay, time's up. Zan, are you ready?
Yes.
Okay, so okay. All right, Zan, can you tell me what have you found in this patient?
I've completed examining this middle-aged gentleman. On my general inspections, the patient appears to be not tachypnic. RR is around 16, and however, the patient looks hexic, and over the fingers, there's noted finger clubbing, but there's no signs of suggestive of CO2 retention, such as palmar erythema or any erytherosis. So on the neck, it's noted that the trachea deviated to the right side. For the chest examination, my findings are confined to the right side, in which there is noticed a down, reduced in chest expansion over the right side, and also um, down percussion note. There's also a bronchial breathing over the right upper zone, and also reduced breath sound over the right lower zones. So the patients also have a loud P2. So in conclusions, I think this patient is having a right upper lung, right upper loop collapse. With the possible causes include malignancy and also post-infection such as a post-tuberculosis infections. Yeah.
Okay,
I would
any
like to
other differentials?
So my other differentials would include yeah, sorry, I can't think of any.
Okay, never mind. So yeah, so how do you investigate this patient?
So I would like to investigate. First, I will start with chest radiography to confirm is there any confirms is there any um signs of suggestion of fibrosis, or is there any consolidation signs? Also, I would like to order from history. Maybe I would like to order some high resolution CT scan to confirm the fibrosis and then the extent of the disease.
Sorry, why do you think that is a fibrosis based on your examination?
Mm, okay, because there's a deviations of the curvature to the right side, which may actually due to some fibrosis and some tractions. Yeah.
Okay, if you're thinking that this is tractional fibrosis, do you expect to hear any craps?
Yes. Yeah. But
Okay,
yeah.
but do you found any crepitation in this patient?
In these patients, no. Yeah.
Okay, so what is uh, the the thing that you want to look at in the X-ray or even the CT?
Yeah. Is I need to look at, is there any mass? Yeah. Any lung mass in the, yeah, evidence
Okay.
of lung mass. Yep.
So
So
let's say this any other investigation you want to do?
I will also need to order a spectrum AFB and also tuberculosis CNS. Yes, tuberculosis may be a possible diagnosis.
Okay, so let's say this patient has TB in the past. How do you manage this patient? Came in because of cough.
Okay. So all right, I need a temperature charting and also a vital signs of patients, and also need full blood count and also inflammatory markers to make sure the patients doesn't have any another episodes of infections.
Okay, time's
Yeah.
up. Okay, all right. So you can see that actually, if I think your presentation is okay, but when it comes to discussion and investigation, you are a bit stuck. And try to make things clear, because actually initially your presentation is good. It's just that I don't know why the fibrosis start to come in, because you didn't mention anything about crepitation and you shouldn't say fibrosis lah. Oh? And then I think you want to mention about consolidation, this word, but you don't dare to use it. And then it
Yeah,
was just collapse.
I was thinking what's the yeah, it's trend line. I forget the term. Yeah, consolidation shouldn't be used in X-ray, I think.
You can use, but you must mention it's a heterogeneous opacity lah. You should expect an opacity which may suggest consolidation. And but your clinical diagnosis is what for this patient? You say it's a lung collapse, right?
Yeah, it's a lung collapse.
Is it just collapse?
Should be collapse consolidation, I think, because it's a bronchial breathing as well, right?
Yeah, but why you
Yeah.
didn't mention that just now?
Yeah.
Now after 4 minutes, too late already. Oh, so in exam it's the same. So you must mention things properly and complete. Okay. Actually, your presentation is good. I would say you got most of the finding and you managed to present it. But in this patient, since you're suspecting TB, right? You must also mention that there's no BCG scar seen. Oh, this particularly, I did mention that, right? No BCG scar seen. Oh, and look at that, the right arm got tattoo marks. Wouldn't that tell you that this patient may be a bit high risk?
Yeah.
Yeah, so that puts the TB at even more likely than other thing. Huh? Yes, definitely there is possibility of lung cancer as well. And if you think this is a right upper zone kind of mass or even consolidation, and in fact I put here for you
Yeah.
already, you didn't mention about that at all.
Yep.
So do you surprise that I write this when in when you're going through the examination? Do you think you will routinely check for this in respiratory station?
Okay, now I know lah.
Yeah, now you know why, right? So because a lot of times a lot of people will forget that respiratory is always very stressful, not enough time. But having said that, a lot of things you are already seeing, but it's just that you're not thinking and to present it out. The only additional thing for this thing that will do it differently than anyone else is after I appreciate there's a collapse consolidation, I will actually go and touch the both hands or maybe just that affected side. For example, that this one is the right side, right? So I touch the right hand. I will actually try to ask whether there's any loss of pain sensation. I mean, you can just ask to show that you actually want to check for Horner, no? Because we know that I think last session we discussed about Horner. This is actually the second level kind of Horner. So second degree kind of Horner lah, no? And then basically if you don't mention if you don't check, it's also okay. During presentation, you can say that there's no obvious ptosis which may point to possibility of Horner syndrome. You can mention like that, okay? But generally, I think your discussion should be more fluent. And actually, you want to look for heterogeneous opacity, especially over the right upper zone. And then you want to look for any cavitation. You're thinking of TB, right? You want to look for cavitation. And also look for any other associated condition. And then CT thorax. Yeah, CT thorax, basically you just want to look for air bronchogram because this is actually a consolidation, right? So it's definitely air bronchogram. Another thing is that if you think this is a cavitation, then you should able to find some bronchiectatic changes or even some cystic changes. Let's say it's due to different etiology, or even this is just any mass lah. You can measure like that. And then regarding the investigation, you should also mention the sputum workup earlier. In fact, you want to measure, but actually the confirm is fine. But bear in mind that you need to save some time to measure all that, the sputum culture, sputum AFB to exclude TB. And in this patient, if you suspect lung cancer, right, you may need to consider image guided biopsy if it's necessary to confirm the diagnosis. Okay. And another thing is that the management. So the management, if you don't have time to manage about to measure about management, like, so just make it short. If you only have 10 seconds, you don't have time to multidisciplinary approach with a focus on patient education and counseling, which already costs 7 seconds. So you must mention a bit more targeted. So mention that I will stabilize the patient vital sign, every breathing circulation, will start patient on appropriate oxygen if it's necessary, antibiotic and workout, isolation, influenza, pneumococcal vaccine, and avoid smoking if patient smoking. Just like that. Okay. So you must make sure that you need to prepare yourself that if you don't have time to mention a lot of things, you must make it as short as possible, but as important as possible. Okay. So I think that's all for this case. So if I go to present this patient, right? So I will present like this. So I will say, sir, this is a middle-aged gentleman who appears caucasic, otherwise not in respiratory distress or needing any oxygen therapy. He has a dry cough. On peripheral examination, I noticed that he has a clubbing. However, there's no evidence of CO2 retention. He's not jaundice, no pallor, and not sinus. There is a right tracheal deviation. And my finding over the lungs is confined to the right side, especially the upper lobe, in which that is the upper zone. Sorry, we shouldn't use the lobe. Lobe is for the anatomy, but clinically it's zone. In which at the right upper zone, there's a reduced chest expansion, percussion downers with a reduced breath sound. However, there's a bronchial breathing with increased vocal resonance. At the right lower lobe, at the right lower zone, there's also some reduced breath sound as well. Okay, functionally, there's no loud P2 or P2 edema to suggest pulmonary hypertension. So my working diagnosis for this patient is actually collapse consolidation of the right upper zone. And I would like to offer my etiology to be pulmonary tuberculosis. It can be some form of necrotizing pneumonia. However, patient does not look very septic. And it can also be some lung abscess or cavitation, mitotic lesion of the lung, or even in the severe case of pulmonary infarct. Additionally, I noticed that patient have tattoo marks over the right arm and there's no BCG scar. And there's also no ptosis or loss of sensation over CAT1 to suggest Horner syndrome, and there's no palpable lymph nodes. Okay, so that's all that I will present. Let's say you don't really check, or even you forget to check for the sensation thingy in the case of collapse consolidation, is totally fine. You can just mention that I will want to check to rule out any Horner syndrome, just like that. Okay, so there's a very flexible way of presenting. Anyone have any question? If not, we will just proceed with the last case and then call it a day. Yeah, Zan, you got any question?
Yeah, no for me. Thanks.
No, okay. So last is actually Izarin. Are you there?
Yeah, I'm here.
Okay. So I think you have listened the first 5 candidate. So you'll be the last one. So yeah, so you know what to do, yeah? So I'll give you 1 minute and then after that we will start. Okay?
Okay.
All right. Oh, sorry. Before that, false alarm. Yeah, this one I think you all can read or even watch the recording from the previous video. I mentioned about reduced breath sound over the lower zone of one side of the lung. You need to think of these 4 possibility. And collapse consolidation is the one that will stand out because it's very different from the rest of the 3. You will have ipsilateral deviation instead of contralateral or central. And then usually you will have bronchial breathing and also increased vocal resonance as opposed to the rest. And the etiology, everyone can go through yourself. This is just a very short form method that for me to actually go through. Let's say when the examiner asks you, so what are the possible etiology for this collapse consolidation? This is how I will mention about it: infection, mitotic lesion of the lung, ischemic, other things like foreign body, blah blah blah. So it's exactly like what I mentioned just now, right? But I just make it simple. Just mention a few things out of this list, lah. Okay. So Izarin, so your turn will be starting like now.
Okay.
Okay, are you ready?
Yeah, sure.
Okay, so Dr. Izarin, can you tell me what have you found in this patient?
Sure. This is a middle-aged gentleman who is catastic. He is currently comfortable with normal respiratory rate, and he is observed to have clubbing. On inspection, noted there is a left tracheal deviation with a pentaneal patch observed and a left lateral thoracotomy scar. On examination of the lungs, noted there is reduced chest expansion, dullness, and also reduced breath sounds over the left upper zone. My working diagnosis for this patient would be left upper zone lobectomy for prior, possibly lung cancer.
Okay. Do you mention about the trachea?
The trachea is deviated to the left. Sorry, I didn't.
Yeah, so your trachea is deviated to the left, and you think that this patient has possibility of left upper lobectomy, is it?
That's right.
Okay. So other than possibility of primary lung cancer, is there any other differentials to suggest this scar?
Yes, other differentials could be patient could have localized bronchiectasis, or patient could also have aspergilloma that is removed.
Mm-hmm. Any other thing?
Other diagnosis could be patient could also have collapse consolidation as well.
No. I mean, as in the
For
the
the
cause,
for the
the reason for left upper lobe lobectomy.
I cannot think of other possible etiologies other than the one I mentioned.
Okay, never mind. So let's say you think that this is a removal of the lobectomy because of lung cancer. What type of lung cancer that is likely in this patient?
Most likely it will be a non-small cell lung cancer.
Okay, non-small cell lung cancer. So you're talking about early stage of non-small cell lung cancer. So let's say the patient has have underwent the surgery. Now presentation noted the symptom wise have been having cough and also excessive weight loss, and then has already defaulted the appointment under the lung cancer clinic, and now she's seeing you. How do you investigate her?
Sure. So I would my primary worry would be if the patient had recurrence of the lung cancer. So I would like to do a chest X-ray first to see whether there's any new lesions that can be seen, and after that I would like to proceed with the CT thorax as well to see, and also possibly PET CT scan as well to see whether there's any recurrence or new lesions for the patient.
Okay, all right. So, okay. So let's say you are dealing with a case of non-small cell lung cancer. How do you manage this patient? Let's say the patient is a fresh case, not in this case, but it's a fresh case of non-small cell lung cancer, biopsy proven. How do you manage this patient?
Sure. So I would like to have a multidisciplinary team approach for the patient. Firstly, I would like to educate the patient. If the patient is a smoker, then I would like the patient to to advise the patient for smoking cessation and also advise the patient for vaccination as well. For the non-small cell lung cancer, I would need to involve other team as well, such as the respiratory physician and also the oncologist. And also for the non-small cell lung cancer, probably the patient will be indicated for chemoradiotherapy.
So you're talking about chemoradiotherapy. So any targeted therapy that you know of?
If the patients have mutations, let's say the EGFR mutation or other genetic mutations, then the patient can be benefit from targeted therapy.
Do you know any class of the medication for EGFR mutation?
I'm sorry?
Any specific class of medication for the EGFR positive patient?
No, sorry, I don't know that.
Yeah, okay, time's up. Anyway, good job. So the answer is actually tyrosine kinase inhibitor lah.
Oh, okay.
It's a TKI, right?
Yeah.
Yeah, now we got PDL1, Pembo, those other targeted ALK gene mutation. But basically, you just need to know a bit only, no need to know too much. And then management, again, for lung cancer, right? Same as other lung disease, always mention about vaccination, stop smoking, and also pulmonary rehab. All these are very important also. Okay.
Okay.
Yeah. So I think your presentation, I would say is a bit short, but I think you cover most of the important points. It's just that you are too confined that you are quite sure that this is a lung cancer. Maybe because I put a very obvious scenario of there's a fentanyl patch over the right upper chest that may suggest that patient is suffer from some form of chronic pain or maybe cancer-related pain.
Yeah.
But again, when you are not very sure, when you're just encountered with just one scar and the trachea is deviated to that side, and you think this is actually a lobectomy, not pneumonectomy, then again you need to tell yourself that what are the possibility instead of just mention that this is a lung cancer.
Okay.
Okay, all right. So we'll just go through the case. If me, I will present a bit longer, but I think it's fine. So you can mention that this is a middle-aged cachexia. Maybe I will just restart again. This is a middle-aged gentleman who appears cachexia, otherwise not in respiratory distress, needing any oxygen. He has a dry cough. And then on peripheral examination, there is a digital clubbing, no signs of CO2 retention, and then no jaundice, pallor, or cyanosis. And then he have a tracheal deviated to the left side of the lung. And then over the chest examination, I noticed that there's a left lateral thoracotomy scar, as well as there's a fentanyl patch over the right anterior chest. My finding of the lung is confined to the left upper zone, in which there's reduced chest expansion, down on percussion, there's a reduced breath sound, but there's no bronchial breathing, and the vocal resonance is actually reduced. There's also some minimal fine crepitation over the left lower zone. Functionally, there's no signs to suggest pulmonary hypertension. Additionally, there's no ptosis or loss of CH31 distribution to suggest Horner syndrome. There's no palpable cervical lymph node. So my working diagnosis for this patient is actually as a left lobectomy, or particularly upper loop lobectomy, in which the etiology can be due to mitotic lesion of the lung, such as the early stage of the non-small cell lung cancer. It can be decortication for the lung abscess or cavitation, or even like aspergillosis or fungal lungs, or even it can be due to bulectomy in the case of recurrent pneumothorax. I will have to complete my examination, blah, blah, blah. Then I just stop there. Okay.
Okay.
So yeah, so this case, I think, do I have, yeah. So again, when you are stuck with the differential, right, you should always think back that means our homework must be good before we go for exam as well. So when you see a wart scar, what are the possible procedure for what indication? And when you see the, let's say, unilateral thoracotomy, what are the indications? So you must have a few, at least I would say 3 differential diagnoses. Like just now, you only mentioned 2, right? One is lung cancer, and another one is more like aspergillosis, which is like a lung abscess, basically. But you need to have more, if possible, maybe 3 or 4.
Okay.
And then let's say for warts, you start from the smallest. That means it's a biopsy of the undeterminate lung nodule, or it can be biopsy or resection of the solitary nodule, or even early stage of lung cancer. It can be decortication, can be bulectomy, can be lobectomy, even using warts. Can be purectomy in a recurrent pneumothorax, but very rare. And unilateral thoracotomy is just decortication, bulec, lobec, and then lung volume reduction surgery. So I don't think I have, or I do have slide. Okay. So again, how to differentiate between lobectomy and pneumonectomy? So maybe I pass the question to Izarin. How do you differentiate whether this is lobectomy or pneumonectomy from clinical examination?
So lobectomy usually you won't have the tracheal deviation, whereas the pneumonectomy you can have the tracheal deviation towards that side of the surgery. And also for the lobectomy, sometimes they can have the lung expansion. So sometimes the findings after a while can be normal, whereas the pneumonectomy you can have the reduced breath sounds, absent lung sounds, and all that.
So the answer is actually in lobectomy. So the trachea may or may not be deviated. Okay, if it's an upper loop lobectomy, then most of the time it's deviated to the ipsilateral side. But let's say it's a lower or even middle loop lobectomy, then usually it's central. Okay. However, compared to pneumonectomy, it's always deviated to the ipsilateral side. Okay. The second point is like what Isaiah mentioned about the breath sound. Breath sound is definitely reduced or even very minimal or even up to usually not absent lah. Absent meaning there's no lung already lah.
Oh,
Memang there's no lung, but usually you will still hear some breath sound transmitted from the contralateral lung. So it's usually it will not fully absent. It's just very minimal breath sound, very reduced. As opposed to the lobectomy, most of the time it can be reduced. It can be normal if the lung is already well expanded. And there's another thing that bear in mind, like what I mentioned just now. Let's say a patient underwent any surgery, any intervention in the lung. Sometimes they may have pleurisy, and if you have pleurisy, and that kind of pleurisy, you will auscultate the lower zone. For example, you will hear some cracks. That cracks is actually not fibrotic. It's a sign of pleurisy lah. That suggests the previous irritation to the lung pleural. Sometimes can cause some thickening, sometimes can cause some pleurisy inflammation. But generally, you may ignore that finding unless it's very severe. You may want to present it's fine. But generally, the idea is the scar with the trachea deviation, you need to give the diagnosis. Okay. All right. It can be also pneumonectomy in this patient. However, less likely because the breath sound is only reduced over the upper zone. And the middle zone and lower zone is actually equal breath sound. Okay. You can present as that as well. Okay. All right. Any question?
no.
You are clear, right? So you are also sitting for exam soon, is it?
Yes.
Which center?
JB?
JB. Johor
Yeah.
Bahru. Oh, so,
Yeah.
okay, all right. You're Malaysian, right?
Yes.
Yeah, because your slang looks like sounds like a Middle East slang. That's why I'm just asking.
Oh, okay.
Okay. So another thing, just to recap, like before we end our session today. So when you encounter a respi scenario, right? So you try to tell yourself whether there's any what are the things that you are actually looking for in terms of diagnosis. So if you go up there, when you look at the patient in general, if a patient is on oxygen supplementation, you try to see whether patient is actually have any CO2 retention. If no CO2 retention, generally it's just type 1. Okay. So type 2 is basically you want to look for pulmonary erythema, bouting pulse, and also any hysteresis lah, or flapping tremor. And then look for the scar, and then look for inhaler and medication at the bedside. And then let's say you are dealing with some form like prolonged expiratory phase, that will tell you that can this be some form of COPD or even asthma. Okay. And then you may also want to look hard for signs of hyperinflation, increased AP diameter, tracheal tach, reduced breath sound, hyperresonance, prolonged expiratory phase, and reduced vocal resonance. If you're talking about suspecting cancer, then you actually want to look hard a bit. For example, any clubbing. Nicotine stain nowadays very seldom have. Usually you will actually can smell the alcohol, not the alcohol, sorry. You can smell the tobacco kind of taste from the mouth, but sometimes they wear masks, so you cannot smell anything. But generally it's not that important. But the important is to look for any hypotonia, muscle wasting, and that will give you clue that whether patient got ptosis or not to suggest Horner syndrome. And then also look for any superficial dilatation of the veins over the upper chest. That will tell you that the patient has some form of SVC obstruction as well. And then cervical lymph node also important. And then also sometimes you look at the chest when you inspect, you see whether there's any marking, just like a small tattoo marking like that to suggest a radiotherapy scar. Let's say there's actually pulmonary hypertension. So you want to see whether there's any raised JVP, loud P2, and also pedal edema. So usually I only look at these three. I don't look at all. So when you encounter a patient with struck case station, when you look at the patient before you feel for the chest expansion, so you actually look at how the patient breathes, and you look at the chest, which side is actually expanding more. So let's say you saw that the left side is actually expand more than the left. So definitely it's asymmetrical. But let's say both are actually similar, and then when you put your hands and then you feel the similar kind of expansion, then this is symmetrical. If it's symmetrical, you should tell yourself that whether you're dealing with more like obstructive lung or restricting lung. Okay, and that can generally you can just gauge from the AP diameter or so-called whether patient lung expansion is good or not. Those like not well expanded kind of lung, you know that it's most likely some form of restricted lung. And then if it is a restricting lung, then you look hard for capitation because that will suggest fibrosis. If let's say there is nothing much clear, but there's a clamshell scar, then you know that this is lung transplant. So let's say this is an increased AP diameter obstructive picture. So you want to look hard for capitation or clubbing. If let's say there is, then most likely is a bronchiectasis. If both no, then most likely you are actually dealing with COPD or asthma. And in asymmetrical expansion, the important thing is actually look hard for any scar. So if let's say there is scar, so you want to know whether this is a lobectomy or pneumonectomy. So usually the scar I mentioned is the lateral thoracotomy. If the trachea is central, then like what we discussed earlier, most of the time it's lobectomy, and especially it's a middle or even lower zone or lower loop lobectomy. And then upper, it can be esophageal deviation as in pneumonectomy as well. The phrenic nerve crash and everything, I don't think will come out. It's too long, too old to come in exam already. But this is just something in our mind. Let's say there's no scar but asymmetrical chest expansion. So you must actually feel for the trachea. If the trachea is central but there's bronchial bleeding, then most likely you're dealing with just consolidation. But let's say there is a esophageal deviation. So this is like what we have discussed, like what I think is undiscussed. It's a lung collapse and there's a with or without consolidation. But bottom line is that there will be a collapse. Okay, and it can also be tractional fibrosis or tractional bronchiectasis, depending on whether there's any crepitation. If this is a contralateral tracheal deviation, no scar but asymmetrical, then you're dealing with something pushing the lung away. It can be massive effusion or massive pneumothorax. But usually these two will not come on the exam. Usually if you come exam, usually you have some chest tube or drain because it's not fair to keep the patient symptomatic and come to exam. But anyway, it should not come in exam. But this is just something to bear in your mind when you encounter different signs and then you want to actually know which direction you're heading. Okay, so with that, this is just okay. I don't think I need to go through this. I think everyone can just have a look. It's basically just non-pharmaco specific in terms of management, and then investigation. You can try yourself how to diagnose and to assess the severity, look for complication or even the etiology. Okay, so this is just a very brief summary. So I hope by the end of tonight, those that attended this session will actually understand that it's important for us to practice, especially even without examining patient. You need to practice your own presentation, because if you practice enough when you really practice in a hospital in clinical setting, then you will present better and more concise. You know what to present and what to say and what not to say. And then also always have a doubt to actually mind map these kind of common cases. These cases are expected. Okay, all these cases that we discuss is expected, regardless of which station, which center. So don't try to guess which center come out what kind of cases, because it's just part of the RCP kind of curriculum. This is something expected to know. So I think we need to prepare for all these possible cases. And then because you have practiced more, and therefore you should aim for perfection. There's no reason you practice cao, but then you cannot perform. So it's not efficient, not efficient. So you must aim for perfection. You will realize that up to a certain point, if you practice the short case more, you will be more confident, and most of the time you can actually present quite well. Okay, but having said that, sometimes we have to expect the unexpected one. So sometimes we have to try to think of the possibility, especially for abdomen. Sometimes the scar can mislead you, and then sometimes you will miss one of the sign and you will not you'll miss the diagnosis totally. So you always expect the unexpected. But in the exam, it's important for us to be honest. Sometimes if you don't do something, you just say, sorry, I forgot to do. Given enough time, I will definitely do it, or something like that. You must admit our own limitation. The exam is to show that we are a safe doctor, not to show how great we are to actually perform, and then to show our technique. It's more like telling examiner that I am safe to become a doctor, to become a specialist. Okay, and definitely before the exam, have to rest well and pray for the best. Okay, all right. If got no question, we will end the session today. Oh yeah, so before that, I noticed the chat box got 2 questions. Do we offer etiology investigation for those patients already on dialysis? Definitely not, like I mentioned, right? So if patient is already end-stage kidney disease, your investigation is more on looking at the complication from the point of end-stage kidney disease, and also from the medication, and also from the dialysis, for example. So you're no longer talking about etiological investigation. You can mention 1 or 2, for example, you don't know whether the end stage is diabetic or not, but to be honest, in real life, does it matter? We don't really look hard for the etiology. Let's say even for those patient, that younger patient, early end stage kidney disease, some congenital nephrotic syndrome, or some other GM, we don't really work out also. So same reason we shouldn't focus our attention to work out on the primary disease, but we can offer the etiology, possible this and that. But in the investigation, we can just mention about the complication, how to manage, how to investigate for the complication. Okay, for example, anemia, renal bone disease, for example, adequacy of the dialysis, KT over V ratio, things like that. Another question is it important to check femoral inguinal region for scar in a transplant case? Any reason why, Jason? You want to check? Yeah. Hello, Jason, are you there? Or you already left? But anyway, it's not important. For abdomen examination, for the short case point of view, we are not expected to examine the lymph node unless you feel that there's some cervical lymph nodes, can be lymphoma, hepatosplenomegaly. You may want to do if you got time, because abdomen usually after you finish whole thing, you got about 1 minute one if you do enough. So most of the time, sometimes you have a lot of times. So in that kind of situation, I may want to offer to and really ask the patient permission to check for inguinal lymph nodes, because I may be suspecting something like lymphoproliferative disorder like lymphoma. Otherwise, we shouldn't check routinely lah. I don't know what's the reason for you to check for any femoral inguinal, probably just to see whether got any femoral catheter, or even like the permanent perm catheter lah, perm cat. But I don't think it's important unless I would say you cannot find any access lah. Let's say let's say you find patient not on dialysis, for example, neck scar removed, Tenkov removed, transplant. Okay, if let's say the transplant is not done, let's say just everything removed, but you know that this patient most likely got Tenkov, got IJ, most likely already end stage, but you cannot find the access, then you may want to check. But again, bear in mind that if you want to check all this private area, you must ask for permission. But this is not something that I will routinely check. Because I think the focus is not at the femoral, the focus is actually looking at the patient as a whole, and then telling the examiner that the patient is on kidney replacement therapy, and which mode is that, and that's more important. Okay, if no question, then we will end the session for tonight. Okay, anyone have any question?